Start. Good morning, guys. So today, let me see the HIEM 3s. Okay, let's start. So let's start with HIEM 3s. So I have a case, 6 years old, woke up screaming with a neck pain, head tilted to one side. How would you manage this case? I can only see 2 of the HIEM 3s.
We can start them on some pain medication, NSAIDs, and give them some local heat, like heat pads.
Okay.
And if it is severe, some physiotherapy later on may help, basically.
Okay, so you have read and come, isn't it? That's the problem having the topic out. Anyway, yes. So this is Torticollis, guys. So it's not very common, but I had a case in Bassett Law 2 weeks back when I was trying to decide a topic. So I thought I'll do this. So that is where it comes from. And it was a 6 years old. So the term is a twisted neck or a twisted collar. That is what torticollis is in Latin. Okay, so either digitally in a paper somewhere or on the your Word document, can you write number 1 to 10? So you will get 10 questions in the process, and you have to answer 1 to 10. So that is your pre and post MCQ type of. At the end, I would be asking how many of the 10 you knew. So if you write a wrong answer, just let me know later that was wrong. So are you ready, all of you?
Yes, sir.
Okay. If you want a Word document, type 1 to 10. If you do in paper, write 1 to 10. So question number 1 and 2 are here. Torticollis is also known as. So write your answer. And acute torticollis can last up to dash. So just write the number 4, 3, 2, 1, or 14 days is in weeks. So you have to answer in weeks. 20 weeks, 25 weeks. Okay, so don't change the answer now. I trust you guys. So it's also known as wry neck. It was on the top already released. The answer was there. So if you have written wry neck, you score 1. So it reflects painful sternocleidomastoid muscle spasm. Most of the time you find it when you're waking up, or sometimes you may find after a sudden neck movement. The acute torticollis can last up to 6 weeks. So the answer, that question 2 was 6. So if you have answered 6, so that you score 1 more mark there. Causes. Name some causes. So you can, so 1 would score you 0.5 marks. So I have asked for 2. So list 2 causes, or if you know more than 2, is fine, write as many as you know, but I need at least 2. So most of the time the cause is not known. So that is not, even if you have written not known, probably 1 mark, 0.5 mark is fine. But these are the common causes. So poor positioning. So the most common these days is secondary to loads of desktop work, inappropriate seating, sleeping inappropriately or with a difficult pillow, and sometimes carrying heavy unbalanced load. So today I'm only talking about the torticollis, that is simple one. There are other differentials which we will talk. I'm not talking about like a discitis or something else, a traumatic neck pain. But what I'm talking about is a torticollis that is benign, that usually lasts short time and goes off. And these are the causes. So torticollis, as you know, is more of a symptom than a disease process. It can be caused. So there are more than 80 different causes that has been said can cause torticollis. In children, it's common in children, and sometimes it is congenital as well. And interestingly, 3 out of 4 occurs on the right side. And this child, I didn't know till I read. So this is the beauty of preparing teaching, isn't it? When I saw the child, he was tilted on the right side. And this is 75% on the right. Relevant basic science is thought to be secondary to musculoskeletal irritation, causing pain and spasm to the neck muscle is a simple mechanism. So on question number 4, you have to say whether it is the first, 10th, 7th leading cause of disability. So like a back pain is very common, isn't it? That's another one. So neck pain is also common. So is it the topmost cause for ringing off sick type of thing? So you have to put a number there, or whichever number you think it is. Can somebody guess?
3.
Olu says 3. Any other numbers?
7.
7.
8%.
8.
I think
Okay.
2.
Okay.
I will put 2, sir.
Some put 2. So you have written your answer, isn't it? So once you write your answer, then only I will bring out the answer. So it's the 4th leading cause. Who wrote 4? Anybody wrote 4? Maybe nobody. So everybody got 9 out of 10 today. So 1 is already so universal.
3 is close to 4, Prof.
No, that you won't score for 3. You have to write 4. So most episodes of acute neck pain will resolve with or without treatment. But sometimes, not sometimes, almost half of them have a recurrent attack or future attacks of the neck pain as well. So this is on the, see, I have done my slides based on Boone's guidelines on epidemiology, basic science, but I moved the topic, some of the slides up, down to just to make a flow happen. But on the top, you will see the Boone's prompts. So every slide I have named it so that it becomes accepted in future that we have what section of the presentation we are doing on that slide. The differential diagnosis. So that is another one that Boone wanted, isn't it? Name at least
Prof,
2
it's a
differentials.
syllabus that wants it.
Yeah. But you are our syllabus, Boone. So you write your 2 differentials and let's discuss a little bit. What have you written? Sundar?
Meningitis.
I heard a female voice for Sundar.
Sorry. So
Oh, meningitis is one of them. Was it Rasika who was talking?
Yes,
Yeah.
sir.
Yeah. Any other things?
trauma,
Tetanus.
Trauma.
Tetanus.
Fracture.
Congenital spinal stenosis.
Okay.
Brachial plexus injury.
Okay. Brachial plexus injury comes with the neck torticollis. I don't know. Does it? Maybe so. Say I don't know. So that I'm not saying it is wrong, but I don't.
Quinsy, tonsillitis, sore throat,
Yeah. Common
all
one.
this stuff, even ear pain cause spasm of the sternomastoid muscle,
Yes.
ear infection.
Mr. J, you looked at the book and then you are reading it out.
No, who is book?
he
No, don't think that I'm that guy.
just
I don't
kidding.
look at the
he
books.
has
I
lots
don't
of
look at the
knowledge. I
books.
don't think he needs books.
I've treated the next pain, I think probably before you go to medical school.
I'm just pulling the leg, Mr. J. I know. I'm
I
just
know.
pulling the leg. I know.
Okay.
Sorry.
So there are So I only wanted two answers. So if you have anything to, these are the common ones listed in literature.
And the most the other thing is rheumatoid arthritis when this atlantoaxial dislocation. So that's very important cause as well. And the sternocleidomastoid muscle, when it's a wry neck, if you manipulate, forcibly, so you can end up rupturing of the odontoid ligament, causing subluxation of the atlantoaxial joint. So that's also, one of the differential diagnoses.
So as I mentioned in my previous slide, that you can have 80 answers for this. Yeah. So many things are there, but as far as I could find, these are the top differentials and the more
whiplash injury, very common.
So
All these comes in there.
cervical disc herniation. If you
Absolutely,
have a referred pain that Aftab was saying, earache, sore throat, quinsy, all the referred pain from different sides can have this. Dystonic reactions. And dystonic reactions are multiple drugs. Cervical arthritis, osteoarthritis that you were talking about, and spinal infection. So these are the common ones, not only the common ones, the ones you should be thinking in all of your patients, because we have to have a safe discharge mechanism, isn't it? So before you discharge, like in chest pain.
I think the other cause is which we see in the psychiatry patient. Sorry to disturb you, Prakash.
Go on.
Is the achillogeric crisis of the, after taking them antipsychotic drugs. So, the people dislike that sort of movement,
I think that comes in dystonic reaction, Mr. J.
Yeah.
That
Is it just a quick question? Is it cervical disc herniation? Is it something very common in children or?
No, this is not common in children. This I'm talking.
No, he's counting
all adults and children.
So we're talking torticollis in general. Sorry.
Yeah, it's come. The torticollis itself is common in children.
Yeah, but the cervical disc herniation is
2021 curriculum. It is highlighted as a children's presentation. Okay, so if you look at 2021 curriculum, it's highlighted in a different color, which is a children's presentation. However, I have brought general things as well. So the thing that are relevant to us. So these things is in the list just to make sure we have a safe discharge. So we don't miss a spinal infection saying it is a simple torticollis. So we have to think of all those things. We'll discuss a little bit further on each of them. So cervical disc herniation. So you would have, the clue is you would have a sensory or motor symptoms. X-rays usually come normal, so don't be guided by the X-rays. And then you may have to think of MRI, orthopedics type of referral. Usually there will be ongoing symptoms for some time. It won't be acute presentation. It probably would be acute and chronic type of presentation. But obviously it comes with a neck pain and muscle spasm. So referred pain that I've already said, quinsy is the thing you should not miss. I'm talking about, again, safety point of view. There are sore throat, okay, even if you send home, probably fine. But quinsy, if you're seeing it's a neck muscle spasm and only concentrate on the neck muscle, not on the throat side or ear side. So let's go back there. So this is just to tell you, don't miss. So question number 6. Dystonic reaction is our topic. Name drugs that can cause dystonic reaction. If you name 2, you get 1 mark. So each one would have a 0.5.
Mesclopramide, cyclizine.
You are not supposed to be telling, because these
Oh,
guys
sorry.
Metoclopramide may not be the right answer. So if you have written your 2, we can start talking. So who will talk? Those guys who don't have a camera on, are you okay to put a camera on, or if not, just talk?
I could just think of metoclopramide. I could not think of other drugs.
Okay. Anything else, Rashika? No, never do.
Stamifil, no.
Operazine.
Okay.
Cyclizine.
Antipsychotic.
Yeah,
Anti-
antipsychotic. There's a big group. Antipsychotic all antipsychotic would bring this. Okay. Metoclopramide is the one that we should not be missing. Will dystonic reaction happen with only one dose of medication?
Yeah, could be, I think.
Yes. So even if you have given one IV shot, the patient can develop within ED. So
Yeah,
lots of psychiatric drugs can
I've done
cause
that, boss.
Yeah.
Yeah, it can happen. I've done that with I think it's in Birmingham. I was given that in the acholagaric and all that dystonic reaction. That was just after 10 minutes of giving metoclopramide. So that's how I remember that.
Mm-hmm. So almost all antipsychotics can cause, but for us, I think haloperidol we use in the department, and we'll have lots of patients coming and are taking psychiatric medication. So you have to think of neck pain as a differential. If they come with a neck pain, drugs as a differential or something that would have caused it. And things to remember is even a therapeutic doses can cause dystonic reaction, and it can happen even a week later. So it doesn't have to be immediately like Altaf was saying, but it can happen up to a week later. So those things are important just to keep in mind.
I think, can I interject here, please?
Yes, please,
because
sir.
it's an interactive.
We talk as much as we can.
Now I think so much so we used to scared to give morphine to the kiddies because of the being sick and giving metoclopramide and anti-sickness. That's why most of the time we just give morphine titrating to the pain to the under 16 years old. I think, but the current development of this andanosterone, that's safe in children. If you have to give morphine and you're worried about vomiting, so choose andanosterone rather than metoclopramide or any other gut mobility drugs. So andanosterone is pretty safe in kiddies.
Thank you. Yeah, you can talk anytime, anybody, because I don't want to be a one-way traffic. Okay, the other differentials, you have to think of arthritis, both osteoarthritis, rheumatoid arthritis. Sometimes we do lateral views of the cervical spine only to look into arthritis. If you are not sure. Spinal infection, as you know, they come with fever, increase CRP, increase white cell count, and urgent ortho referral. Any bone infection anywhere, we would refer to orthopedics anyway, bone and joint infection. Investigation wise, mostly it is a clinical diagnosis, the simple torticollis, isn't it? Unless you have something else, which. So what are the features in history or examination, right, two, that suggest it is a typical torticollis? And each one would score 0.5 marks. People is still writing. Okay, Rosina has finished. Suchit has finished, is it? No, is it still writing? Sikandar has finished. So people I see have finished. What have you written? Any one of you?
Patient slept.
So I've written like neck stiffness, ear infection, cold symptoms, and sometimes swollen neck, lymph node.
Okay. I have written 4.
Yeah.
Fine. So the history is the most important thing. Okay, so
history of sleeping in a high chair. Maybe child slept off in a high chair, or slept in an awkward position, or woke up from sleep in the morning and started complaining of neck pain.
Yeah, this child we saw 3 weeks back now. The history is very important. Drug history, occupational history, any neck movements, any unexpected things. A physical examination, you only have to distinguish whether it's a real muscle spasm pain or a neuropathic pain. There's no muscle spasm, but it still has a neck pain. This is the thing I was looking for. You have to exclude serious abnormality. And still we haven't come to our answer. So all these things. So the detailed history is important to look into so many things. And for your answer, typical features of torticollis, that benign torticollis I'm talking about. If you have answered any 2 out of those 4, sudden onset, severe unilateral pain, so it's like waking up from sleep with a pain, restricted and painful neck movements, diffuse tenderness on the involved side, and palpable spasm, or with palpable spasm. So out of those 3 or 4, whichever way you say, if you have written 2, you score.
I think it's very important that Prakash is saying that, because our clinicians should be able to differentiate whether it's just a wry neck, which is a benign condition, that Prakash is saying. And mostly we see kiddies coming in the AD. Mom come with the children with the twisted neck, and they say, oh, he slept okay last night, and in the morning he's crying and whatever. And the other thing is to differentiate the red flag sign. So, so whether it's a wry neck or there's any sinister things are going on.
And then the other thing you guys have already said, I think Sikandar was saying, you look for other things as well. So because we would discharge this patient, we have to make sure there's not something else going around before we call it the wry neck. Move on. I think you probably would write this answer already. Okay, I'll not ask anybody. For neurological symptoms and signs, systemic features like malaise, fever, unexplained weight loss. We have discussed this in the previous slide in a different way. And trauma, osteoporosis. So any one of those 3 or any 2 of those 3, you would score 1 mark. Move on. So this is the most important one. Write 2 treatment, whatever 2 things you would do in ED, and then we'll discuss a little bit. I can see 2 Saurabh. Is it Saurabh with a photo and Saurabh without a photo?
Yes, sir.
Okay. You have logged in twice.
Yes, sir.
Okay. So what have you written in your treatment plan?
Saurabh, you're gonna get only 1 certificate, man. You're not gonna get 2 certificates for that.
That's all right.
Yeah, you'll get only 1 attendance.
So I've written reassurance to the parents and oral painkillers, analgesics such as paracetamol, NSAID.
Any other answers?
I think one treatment I find very important is reassurance, especially to parents.
Reassurance to parents is?
I think what I've tried in children, I don't, in adults, I've used diazepam, but in children, I've asked mums to give the massage of the trapezius, upper back, and I think that's unconventional, not probably written in the books, but it works. Because you say if it's a muscle spasm, it's a proper torticollis that works.
Okay.
In the olden days, they used to use a collar, but it's been found that makes things worse than making it better.
Yeah, we don't use soft collar anymore, isn't it? Your soft collar used to be used. Okay. I think everybody agrees, and everybody might have written simple painkillers is the number one thing you do. Local hit is thought to be, I don't know how to give local hit in ED. Any thoughts? I know we can't give a local hit.
I think back home, what we used to do, we used to, warm towel wrap around the neck and wait for half an hour or so. And when you review the children, they used to be okay.
Okay.
You could try doing a glove filled with hot water.
Yeah.
Okay.
Tied off.
So if the glove breaks, then you have a burn. But I haven't tried that. I think a good thought, isn't it? Glove filled with hot water, maybe wrap it with a small hand towel or something.
Yeah, if you just use water from the tap, so it's
and that doesn't burn as well. It's okay.
Yeah.
Yeah. Oh, great. So
but in Doncaster, what normally we do is, when the kiddie come in, we give paracetamol and ibuprofen together, and then we review after about half an hour. Most of the children get better. Even as a matter of fact, the adult as well. Because we use our cocktail is the back pain, and an adult couple of cocodamol, diclofenac suppository, or naproxen, and 2 to 5 milligram of diazepam. So the usual back cocktail in the neck pain as well. In children, because we can't give too much, so we could give some paracetamol and non-steroidal anti-inflammatory drugs like ibuprofen together. And most of the time, things settle down if there's no other underlying pathology.
So these are the 3 treatments that is written in Oxford Handbook of Emergency Medicine.
Yeah, you're right. Physiotherapy helps as well.
And reassurance and telling them that it resolves usually 24 to 48 hours. Usually that also helps, safety netting. So treating dystonic reaction, not the simple torticollis. So how would you treat dystonic reaction? Just write your answer. That I think this is your number 10 and we have done, isn't it? Ankit, what did you write? Are you there or you're not there?
Yes, sir, I'm there, sir.
Okay. How would you treat dystonic reaction? It's fine, you don't need to know. Anybody else?
IV procyclidine.
Okay, procyclidine is one answer. Anything else?
Benchtropin.
Okay. That is the treatment. You can give TTO to take home. Diazepam also works. This child, the one I was talking, did not get better with NSAID, so we had to give him a little bit of diazepam. And then we did land admitting him because he was still painful, not settling down. Probably PEDS might have discharged later. And I kept for 2.5 hours. Did not work. Okay, anybody can tell me mechanism action of procyclidine?
Anti-Parkinsonism. It has a kind of an anti-Parkinsonic action. So
you mean dopamine inhibitor?
Yeah. So yeah, it works as kind of an anti-Parkinsonian action, like a dopamine inhibitor. So to work in places where you have excess anticholinergics.
So is it anticholinergic or procholinergic or?
It's an anticholinergic, isn't it?
Anticholinergic, yeah.
Yes. So the new curriculum encourages you to bring more of basic sciences, isn't it? So I have included here and there wherever I come, not going into too depth, but still a little bit of touch, which is relevant to us. So that's it. Let me come off. Oh, I'm bang 1935. So 30 minutes presentation. Well done today. Any questions?
Yeah, I have a question, Prof.
Yeah, go on.
It's basically for the juniors. Suppose if you see an elderly male presenting to the emergency department, woke up like it's a case scenario, 80 years old male, woke up early morning, severe right-sided neck pain, has been pain not relieved and suddenly has a collapse and is brought to the emergency department by ambulance. What is the red flag differential diagnosis you can think of as a life-threatening emergency in this patient?
Did you say collapse as well, Amitabh?
So woke up similarly, like what presenting common symptom of a torticollis, right-sided neck pain, spasm, woke up with that, but then the pain didn't relieve, pain more progressively getting worse, and then had a collapse. That's the reason his wife called the ambulance, and now he's in the emergency department holding his right side of the neck. What do you think?
I think, is it like a dissection type of picture?
Yeah, vertebral artery dissection.
Yeah.
Yeah. So in that case, what do you do?
Give compression on one side.
Compression on one side. Are you going to stop a dissection?
No. I think by compressing, probably his brain will suffocate from the blood, and he might die to level 4. I think it's a usual set of management as you manage in any dissection. So ease the pain, control the blood pressure, and then investigate it really. And it's a time critical condition, and get rid of this patient ASP, to some other people who can do definitive treatment.
Yeah.
So you might give labetalol to bring systolic blood pressure below 150 or something, because sometimes the blood pressure is quite high. And in this situation, you might get some neurology as well, especially the cerebellar sign. When there's acute pain in the neck, terrible pain in the neck, and you can see some neurology as well, because mostly it's a vertebral artery dissection. And if the carotid artery dissected, you might feel bruit or a thrill or bruit with auscultation onto the neck as well. Mostly these are the work, is it? Because people might be painting or minor accident, yesterday or day before yesterday. They're a little bit history as well. So, just be mindful asking, what you are doing yesterday. Have you done something, or have you suffered any trauma or something? So most of the time, there's a little bit history coming forth as well, that I was painting or have a minor road collision accident, something like that. So then, especially as a young people, comparatively, who suffer with it.
Yeah. I had a similar case in ED a few months ago. The patient came in with confusion, some dysarthria, and it was like a stroke. And unfortunately, stroke nurse didn't come down because he was on break. After we quickly did a CT, we made the patient came, we thought it was an acute stroke, did a quick CT. CT came back normal, but luckily, thank God for the stroke consultant who was worried and said, okay, let's look properly, and did a lot of ultrasound, and they found a big thrombus in the carotid, an occluding thrombus in the carotid. That's the cause.
Excellent. There was no bruise on the neck though, but the artery must have occluded it, so there'll be no bruise when the artery is occluded.
There won't be, but honestly, Mr. Junjo, I'm sorry, I didn't. That day, I didn't examine the neck for bruise. I just went straight for CT.
No, normally, yeah, you're right. We don't check it, but it's a good practice. I don't check as well. Good practice, people with strokes, so just putting stethoscope on the neck, side of the neck, just about 30 seconds. So I don't do normally as well, but it's good practice.
Yeah, that's true.
So
this is a good discussion, is it? It's a good discussion.
Yeah, good.
Yeah, I think I'm always worried about the neck torticollis. The cervical spine dislocation is a very important differential diagnosis, and if we don't think we miss it, that's important as well.
Yeah,
I think, yeah.
Sorry, you're gone.
No, you go.
Now, I was saying when I took this child on that day, I was not completely.
Yeah, absolutely.
I have lost the toss. I couldn't think of many differentials, and I had to Google out a few things before I started treatment. And then I thought I'll come back, I'll do a presentation. As Boone says, 90% of this presentation is for me, isn't it? And so you will only take around 20% or so. I usually is my rule. I spend 10 hours preparing presentation, whatever topic I do, and that gives me loads of ability to talk to the audience, and there are many things that did not come into the slides, isn't it? But there's so many things I've learned in the process. Not here.
Background research.
And it's always better to pick a topic you don't know for teaching rather than a topic you know, so that at the end of the session you would have gained something. Like if Aftab and me and Altaf are doing this, I think you guys should do more of this. Like pick a topic you don't know and then rack your head around for 1 week or 2 weeks. I started 2 weeks back. Because I had to spread up my 10 hours, I couldn't do it in short space. So I had to start a little bit early. So, but this has helped me as well. So probably, so who is scored 10 out of 10 before I move on to the next presentation? Nobody? Who is scored 9? Yeah, all who scored 9 and fresh FR cam. Anybody score 8? 7? 6?
Yes.
Sikandar Saurabh 6. Okay. 5. Okay, 5 there are. So this is what it is. Even 1 or 10 or 20% increase in your baseline knowledge is good benefit to come to teaching. Okay, I think we have Professor Lamsal here, our next presenter. I will introduce